Good morning, everybody. It gives me great pleasure to be introducing you to Professor Kypros Nicolaides, who's Professor of Fetal Medicine at King's College Hospital in London. He's in fact actually Professor of Fetal Medicine in the whole world. And if anyone who works in fetal medicine, I don't really have to introduce him because we all know him very well. He's changed the face of fetal medicine. He's published in over 1,200 scientific journals. He's received many scholarships, honorary fellowships all over the world. He is chair and founder of the Fetal Medicine Foundation, which is world famous, which has made it's a charity that has made a huge contribution to women and their families in the world through promoting research and training. Welcome, Professor Nicolaides. He's going to talk to us about state-of-the-art fetal medicine.
Thank you very much, and it's a pleasure to be here today. I will discuss one aspect of fetal medicine, which I think has had most progress in the last couple of years, and that is in relation to screening for chromosomal abnormalities by the analysis of cell-free DNA in maternal blood. And I start off by showing you the new building of the Fetal Medicine Foundation in collaboration with King's that will be up in September this year. And I'm sure that some of you, or many of you, will be visiting there in years to come. The story of Downs started 150 years ago with an Irish physician in the East End of London, Langdon Down, describing a group of his patients as having some common features. He said in a politically incorrect essay on the observations on the ethnic classification of idiots in 1866 that they have three features that are common. One, their skin is too large for their body, their nose is small, and their face is flat. It then takes 100 years for this phenotypic expression to acquire a scientific basis. And the man that has been instrumental in destroying more fetuses with Downs was a Catholic, pro-life pediatrician in France that adored children with Downs. But there you are, in 1959, Jérôme Lejeune described that the scientific basis of Downs was trisomy 21. It then takes very short time, once you find the scientific basis of something, to create a new process of diagnosis. 1966, a paper in The Lancet describing how you can do an amniocentesis and culture the cells to do the fetal karyotype, and a year or two later, the first prenatal diagnosis of Downs. Now, you have the phenotypic expression, you have the scientific basis, you have a methodology of diagnosing the condition. There's only one thing that is left, and that is a few screaming women demanding the legal right to have a termination. And it was in 1966 that the British government was forced by these screaming women to legalize abortion. You now know how to diagnose the condition, and it is legal to do so. The next step is for somebody to introduce the test under political pressure. In the early 1970s, the government decided to offer a test to 30,000 women. Now, how do you select these 30,000 women in England? By the way, 30,000 in England was equivalent to 5% of pregnancies. They had a paper from 1909 in the British Medical Journal that suggested that there was a relationship between Down syndrome and increased maternal age. So they asked the secretary of the Minister of Economics to identify the 30,000 slots that the government could pay for, and the secretary drew a line at the age of 35 because the 30,000 slots were filled up from the age of 50 downwards to the age of 35, and that created a major biological phenomenon on which generations of doctors were brainwashed to believe that something happens the midnight of your 35th birthday. You are a spring chicken, extremely beautiful until 1 second past midnight, and then you are extremely ugly and old, and the screams from your face looking at the mirror the next morning break the world, and therefore obstetricians see women, they ask them how old are they, and then at the sound of 35, they get extremely distressed, and they say, don't worry, we'll come to your rescue and do an amniocentesis to save your life. And that process carried on for 30 years, and they realized something extraordinary, that it is true that prostitutes are at increased risk of having cancer of the cervix, but the vast majority of women with cancer of the cervix are not prostitutes. It is absolutely true that as a woman gets older, her chances of having a baby with Downs are higher than if you are younger, but there's a hell of a lot more younger women than older women, and therefore 70% of the babies with Downs are in the younger, not the older age group. In statistical terms, if you do an amniocentesis in every single woman over the age of 35, you will end up doing an amnio in 5% of the population in 1970. Nowadays, it's about 25% of the population, and then you will only diagnose 30% of the cases with Downs. And then we had an era in the 1980s where people were measuring various hormones in the mother's blood, and if you combine that information with maternal age, and you selected the high-risk group on the basis of this combination of age plus second trimester serum biochemistry, you could now diagnose 60 to 70% rather than 30% of the babies with Downs. And there came the early 1990s where by accident we found that a high proportion of babies with Downs have a collection of fluid behind the neck, and we called it the collection of fluid behind the neck. Because by ultrasound it looked black, so we said the black space behind the neck, nuchal translucency. And then he combined maternal age, the collection of fluid behind the neck, and various hormones in the mother's blood at 12 weeks, and then we could identify 90% of the babies with Downs, and about 95% of those with trisomy 18 and 13 for the same invasive testing rate of 5%. In the subsequent years, we realized that if you measured some other hormones, like placental growth factor, which was reduced in pregnancies with trisomy 21, 18, and 13, and look at a few other features by ultrasound, like the presence of hypoplastic nasal bone, tricuspid regurgitation, and abnormal flow in the ductus venosus, you could now identify 97% of the babies with Downs at a false positive rate of 3%. So here we had an evolution over a period of 40 years from the description of the scientific basis of the condition, methodologies for prenatal diagnosis, and improving rapidly every 10 years methods of identifying the high-risk group. In the meantime, we learned some other things. We learned that if you had increased fluid behind the neck and you did not have a chromosomal abnormality, that could be a marker of a whole range of other dysplasias, skeletal dysplasias, cardiac defects, and an increasing list of conditions of genetic syndromes that nuchal translucency would be unmasking. We could also, in our attempt to measure this black space behind the neck, realize that you could diagnose a lot of various major fetal abnormalities: top left, anencephaly, holoprosencephaly, exomphalus, gastroschisis, megacystis, obstructive uropathy, body stock anomaly, where half of the body is in the amniotic sac and the other half is in the coelomic cavity. The most common fetal abnormality is congenital heart defects, and more than half of them can now be easily detected directly at the 12th week scan or indirectly, because babies with increased nuchal translucency have a higher incidence of cardiac defects. And then on the right is a description of how, if you look for the nuchal translucency, and then in the front of the body you can see the nasal bone. If you walk through it, through the head, you will see a big black space in the middle of the head, and because it's in the middle of the head, it's called the midbrain, and it's black. And then if you go further down, you will see the sphenoid bone in the middle, and then in the posterior fossa behind that, you will see the brainstem, the fourth ventricle, and the cisterna magna. And in babies with spina bifida, you have the Arnold-Chiari malformation. Amniotic cerebrospinal fluid is lost through the lesion, and then the brain is pulled down. And as the brain is pulled down, that expands the brainstem and constricts the cisterna magna, and you can easily see it in the same ultrasound picture, S for the measurement of nuchal cytosis. So a whole range of fetal abnormalities can now be detected in the first trimester, and therefore that shifted prenatal diagnosis to the 12th week of pregnancy. We also realized that if you take a blood sample to measure Frimida HCG, PAB-A, and PLGF as a method of screening for Downs, and the baby does not have a chromosomal abnormality, you could have a whole range of other pregnancy complications. And that led to a new era where we are aiming now to identify pregnancies at high risk of preeclampsia, fetal growth restriction, diabetes, most pregnancy complications from the beginning of the pregnancies. Here with an algorithm that combines a few maternal factors with the measurement of blood pressure, mean arterial pressure, blood flow through the uterine arteries that supply the placenta, and the measurement of Frimida HCG, PAB-A, and PLGF in the maternal blood, we could identify about 80% of the pregnancies that will subsequently develop preeclampsia. And the same in terms of identifying pregnancies that will deliver very, very small babies due to impaired placentation in the absence of preeclampsia. Combination of maternal factors, mean arterial pressure, uterine artery Doppler, placental growth factor, and PAB-A. The biggest challenge, of course, in obstetrics is premature birth. More than 1 million children die throughout the world every year because of prematurity, and despite all efforts in the last 50 years, the rate of prematurity is increasing. In developed countries, I feel we can identify a high-risk group from the beginning of the pregnancy through a combination, again, of the same logic. Mathematically biased algorithm, combining a prior risk based on maternal characteristics and a series of biophysical and biochemical markers. Here, the measurement of cervical length and maternal serum alpha-fetoprotein, which is increased in pregnancies that subsequently deliver prematurely. Diabetes, for 50 years, the obsession of diabetologists was to develop good methods of identifying the high-risk group at the end of pregnancy, an ultimate idiocy, because by that time, you will not be able to do anything very much to change the course of the disease. Whereas the challenge really is to identify the high-risk group in the beginning of the pregnancy and alter the environment in which the baby is developing if you really want to decrease the prevalence of the complications of diabetes. And that can be achieved in the first trimester of pregnancy through, again, a series of maternal characteristics and maternal serum biochemical markers like adiponectin and tumor necrosis factor receptor 1. This whole era was leading to one conclusion for me. In the 1990s, there was no, in the 19th century, there was no prenatal care. If you were extremely wealthy, you could have a midwife attend you for the delivery. And then in the beginning of the 1900s, somebody realized that perhaps that approach had to be changed. And a Scottish physician who suggested that we must do two things. We must offer pregnancy care to everybody, irrespective of their wealth. And secondly, we must concentrate in the prenatal period, not the intrapartum period. He was, of course, completely ignored, as always, by the medical establishment, but a group of terrorist women listened to what he said. This was a group of middle-class women that went around throwing bombs, being arrested by the police. They were put in prison, and they were going on hunger strike, so they were being force-fed, like the Guantanamo Bay inmates. And then when they survived and they came out of prison, they would throw a few more bombs, and they would chain themselves up in the House of Parliament. They would throw their bodies in front of the chariot of the king and get killed. These women were not completely psychiatric. They were demanding the vote for women. And unlike the medical profession, women realized that demanding the vote in itself is an empty concept unless the vote leads to some acquisition of certain new rights. So the suffragettes, which was this terrorist organization in England in the 1900s was demanding the vote, and it was demanding prenatal care for all women. Eventually, after a lot of screams, they managed to get the vote, and as you would expect of women, when you give them something, they are unpredictable in their behavior. The Conservatives gave them the vote, and the first thing they did, they voted in the Liberal Democrats. The first action of the new Liberal Democrat government in 1929 in England was to introduce prenatal care. And an alcoholic lawyer, Minister of Health in England, acquired an evidence-based model of how we should conduct prenatal care. It was fully written in the Cochrane database. He said, this alcoholic lawyer, we must see women in the 16th week of pregnancy for the first time, and then we must see them again every 4 weeks until 28 weeks, and then you must see them every 2 weeks until 36 weeks, and then every 1 week until delivery. In the Kandahar district of Afghanistan, and in New York, and in London, and in every village of any developed and undeveloped country of the world, we are following, like the Bible or the Quran, this model of this alcoholic lawyer of England of 1929. This is the scientific basis of current prenatal care throughout the world. Now, this model of prenatal care implies two things. That number one, all of the serious problems of pregnancy happen at the end. And number two, we cannot predict any of these problems. And that was absolutely true in 1929, but not in 2015. Now we can predict most pregnancy complications from the beginning. And if that was the case, you must invert prenatal care on its head. The first assessment must be at 12 weeks. And on the basis of that assessment, rationalize the subsequent care for patients. We don't need to carry on seeing them every 4 weeks and touching them and listening with the toilet roll on the fetal heart rate in an idiotic pursuit of a model of 1929. We have to assess people in the beginning of the pregnancy, define their risk of developing pregnancy complications, and then treat them to reduce the prevalence of those pregnancy complications. And then we can see them again at 22 weeks to reassess the risk, and then at 36 weeks for the delivery. So what we learned during this trip in search for Downs is that the markers of better screening for Downs could identify other pregnancy complications, and that created the challenge of a new model of prenatal care. But let me go back to Downs. Now, in the 1990s, people realized that when the cells die, the DNA from their nucleus is broken up into fragments, and they're released into the plasma. So you have cell-free DNA. And in pregnancy, there is a lot of activity within the placenta, and a lot of placental, fetal DNA fragments are released into the mother's blood. And there they are mixed up with DNA fragments from the mother. The challenge, of course, is how to distinguish between the maternal and the fetal DNA. In Abu Dhabi, you have big buildings, but you also have them in London. The biggest building in London is belonging to the Qatari family. And let us pretend that when they were building this building, they used different color bricks for each floor. Then let's suggest that perhaps, God forbid, there will be a terrorist attack on this wonderful building, and the whole building will collapse. And the collapsed building will contain a rubble of different colored bricks. Because you have a lot of unemployed people in England, you will get lots of workers to go around now and pick up these bricks and separate them according to their color into different piles of bricks. So that at the end, when you count the different colored bricks, you can work out how many bricks were used for the building of each floor. Now, could the same concept apply in fetal medicine? Of course, the answer is yes. You have these DNA fragments that have come from the baby and from the mother. They are inside the mother's blood, and nobody knows where did they come from. Then you need a technological advance next generation sequencing, which is essentially a very expensive weighing machine at $500,000. It sequences each fragment of DNA, colors each brick into its different components, and then puts all of the DNA fragments that come from each different chromosome into a pile, so that you know now how much DNA came from which chromosome. And if you have a pregnancy with Down syndrome, since 10% of the DNA in the mother's blood is placental or fetal in origin, if the baby has Down syndrome, then instead of contributing 10 units of DNA to the mother, it gives her 15 units. She has 90 of her own, 15 from the baby, a total of 105 units of DNA in the cases of Downs compared to 100 units in the cases of non-Downs. And this expensive weighing machine can tell the difference between 100 and 105 units. In the last 3 years, a series of studies were published, and we did a meta-analysis only last month published of all of these studies in the last 3 years. And those show that in more than 1,000 cases of Downs, the detection rate of this new approach of analyzing the maternal blood is 99%, and the false positive rate is 0.1%. You will see the name Assure in various of the papers on the left, and that was a local girl from Abu Dhabi that has been working at King's for the last 15 years, and she's returning back to continue her studies and her career in this country. So it is great that your country has contributed to this major development in fetal medicine. Now, the studies have shown that with cell-free DNA testing in maternal blood, we can detect more than 99% of the cases of Downs, 96% of those with trisomy 18, and 91% of those with trisomy 13, all at a combined false positive rate of less than 1%. Now, in twin pregnancies, we have a problem that usually if one baby is affected in dichorionic twins, the other is not. So the problem there is that the cell-free DNA from the normal placenta will cloud the effects of the cell-free DNA from the abnormal baby, and therefore the performance of screening in twins is not as good as it is in the case of singleton pregnancies. Detection rates still quite good, about 97%, not 99%. So that is the performance of screening of the new test. But then we go into the interpretation of the results for the individual patient. And this is where I know I will lose most of the audience, but it doesn't matter. So let us take a population of 10 million people. In most developed countries, 10 million people produce about 100,000 pregnancies every year. In a population of 100,000 pregnancies, we would expect at the rate of 1 in 500, about 200 fetuses with Downs, and proportionally 80 with trisomy 18 and 30 with trisomy 13. We do this cell-free DNA test in this population, and then you can see that we will pick up 198 out of the 200 Downs, 77 of the 80 with trisomy 18, 25 of the 28 with trisomy 13. So in total, we will pick up about 300 of the 308 cases of trisomies. So we will miss some. But at the same time, the false positive rate means that we will also pick up something like 349, so more than those that are affected that are normal, and we will falsely call them abnormal. So this is a new test that it's a screening test. The American companies, of course, because it was quite expensive, gave it an American name, non-invasive prenatal diagnosis, which is completely false. It is not a non-invasive prenatal diagnostic test. It's an extremely expensive and good screening test that requires confirmation with an invasive test. So marketing is one thing, medical care is another. So how do we interpret the results for the individual patient? There's a terrible mathematical condition called positive and negative likelihood ratio. The positive likelihood ratio is when you divide the detection rate by the false positive rate, and it means that when the American companies or the Chinese, they're equally competing now for the market, give you a result from their non-invasive prenatal test saying Downs, it doesn't really mean Downs. It means that the risk has gone up by the amount of the likelihood ratio. It has gone up by 1,000 times. And when they say the baby is normal, it doesn't really mean that the baby is normal. It means that the risk has gone down by the likelihood ratio. For example, if the baby, if a woman has a background risk of 1 in 100,000, and the cell-free DNA test comes as being positive, it is not positive at all. It means that the chances have gone up by 1,000, but because her background risk was 1 in 100,000, it means that now that the result of the test is positive, that she has only a 1% chance that the baby is affected. I hope those of you that are involved in obstetric care understand that, and they do not act on a false positive result, but they confirm the test by invasive testing. And the other way around, if we look at the very bottom of that slide, if the background risk of a woman is 1 in 2, and the result comes back as being negative, it says normal, it doesn't really mean normal at all. It means that the risk has gone down by a factor of 125, so the 1 in 2 is still a relatively high risk in obstetric terms of 1 in 250. And then when you look at another condition like trisomy 13, a negative result, if you were to find a major fetal abnormality, only reduces your risk by a factor of 11. Let's leave this and move on to something that is more interesting. Now, I said that 10% of the cell-free DNA in the mother's blood is fetal in origin. If the baby has Downs, instead of having 10 units from the fetus, there are 15 units. If the fetal fraction, which is the proportion of cell-free DNA in the mother's blood that is fetal in origin, is higher, it's 20%, so 80 units of maternal, 20 of fetal. The baby has Downs. Instead of giving 20 units, it gives 30 units. 30 plus 80 is 110. So the separation between normality and abnormality is bigger. But as we go further down in the fetal fraction, the proportion of cell-free DNA in the mother's blood that is fetal in origin, the ability of these techniques to distinguish between normality and abnormality becomes weaker. It's the same as with any biochemical or biophysical test. You can see on the very top left, the greater the fetal fraction, the greater the separation between normality and abnormality, and the other way around, the lower the fetal fraction, the greater the overlap between the abnormal, the red lines, and the normal, the blue lines. And again, one of the most important contributions in this field was done by the local girl, Galia Ashur, in a study where we showed that the fetal fraction is dependent on two things: placental function, which is the contributor of fetal DNA into the mother's blood, and the maternal weight. The heavier the mother, the more you dilute the placental product that comes into the mother. And then we developed a series of scientific models where you take into account the fetal fraction in interpreting the results for the woman. So if the fetal fraction is only 4%, there's a greater overlap between normality and abnormality. Therefore, the reliability of the test is much less than if the fetal fraction is more than 8%. Now, the American companies competed in terms of which is better. We are a bigger Big Mac. We are a bigger Coca-Cola. We have a nicer wrapping to the Coca-Cola. So the various cell-free DNA companies were competing as to which ones they could give more for the customers, especially in a way that the customer could not understand what it meant. But because it was bigger, it was better. It had to be, because it was a bigger Mac, a bigger Coca-Cola. It must have been a better Coca-Cola. So the companies were giving the fetal fraction, but they were not telling you what to do with the fetal fraction. They were telling you that the cell-free DNA test is good, the baby is affected or not affected, and they were being forced to give the fetal fraction so that when the baby is born abnormal, having told you that it was normal, it would be your responsibility, because they said, we told you that the fetal fraction was only 4%, so you should have interpreted the results appropriately. It's not our fault, it's your fault. And we have all of these interpretations based on the fetal fraction. Now, let's leave that because we're running out of time. There are two models of clinical implementation of the cell-free DNA test. One is to do it for everybody, or to do it based on the results of a prior screening. I worked out here that if you were to do it on everybody, and the cost of the test was only £200, then in order to pick up the last few cases of Downs, you had to spend £6 million per case. And I think that that is completely inappropriate, especially when I come from Greece, where 60% of the youth is unemployed. And in many European countries, a high proportion of the population are employed, and it is inappropriate to be doing a test on everybody, which would be not cost-effective at all. A better model that has been worked out is to do the previous method of the combined test on everybody, identify a very high-risk group that would benefit from invasive testing, a very low-risk group which is nearly 87% of the population that do not need to have any further screening, and then an intermediate risk group that would benefit from the cell-free DNA test. The final thing, in the next 2 minutes, is that the new approach to screening with next-generation sequencing, cell-free DNA in maternal blood, has opened a Pandora's box of the ability to potentially screen for many more things than we were used to in the last 50 years. And that is partly good and mostly bad, especially when we are not ready to understand what the results mean. In many, many countries, and already I know that in this country, it is becoming very trendy to put an extra tick on the form and ask for fetal sex determination. Let me tell you that this is criminal and medically completely inappropriate and negligent. The companies themselves, when you read in between the lines, acknowledge that the failure rate to give you an accurate result is a lot higher than in screening for Downs. Diana Bianchi, a major player from the United States, the most important company, Verinata, who is owned by Illumina, the company that makes the DNA sequencers, is acknowledging a failure rate of 12.2% in giving you results in terms of fetal sexing. And the total number of cases that have been tested is extremely small, and the performance of screening has not been worked out. And the question from the medical point of view is, why are we screening for conditions that don't really have any important consequences for the individual? For conditions where, more often than not, you may be unmasking a problem in the mother that she never knew that she had. 90% of women with 47XXX have a completely normal life, and they have never realized that they had a problem until we decided to tell them at the age of 40 that they have a problem. So to me, this is completely wrong. Something that is interesting is that now you can diagnose a series of microdeletions, DiGeorge syndrome, Prader-Willi, Angelman, and so on, Credusha, from this cell-free DNA analysis. And the companies, again, the big Macs, are promoting this as a major advance. To me, it's a major, major disaster. They have not tested, they have not done any of the scientific studies. They have promoted the test for themselves as being great. They have not told us what is the performance of screening, Nobody knows what is the detection rate. Nobody knows what is the false positive rate. There is a very high failure rate, but they're selling the test, and we, the idiots, are buying it, and we are passing it on to our patients, pretending that we care for them. Nobody understands what these tests mean, and if you do understand how bad it is that we are introducing this test, then you are medically negligent, and if you don't understand, then you're stupid. So the conclusion for me is that we have learned about major new developments that have come at the back of the story of Downs. You describe the phenotype. That's what good doctors do. They look at someone and say, there's something wrong with this person. And then it takes 100 years, nowadays it takes much shorter than that, to describe what is the scientific basis of this phenotype. Once you find the science behind the phenotype, then things can move very quickly. And things can move very quickly, which is good, but things can sometimes move too quickly, which is very, very bad. And in the context of cell-free DNA testing, that is the last of a series of developments in the last 50 years with fantastic results, but major challenges, so that when we introduce them into clinical practice, we do so without producing more harm than good. Thank you.
Thank you very much. In a society where NIPT, I won't say NIPT, I beg your pardon for saying NIPT, but cell-free DNA testing is being performed quite often by obstetricians without the prior knowledge nor the ability to assess the fetus. What are your thoughts on that? Yes. And do you believe that cell-free DNA should be part of a fetal medicine setting?
Thank you very much. This is why I support and I feel excited by the development of these King's clinics, because I think that it is important that there is an interaction between leading scientific centers and the evolution of these centers into providing a clinical service. Some people can be very cynical about what are the objectives and the commercial interest, but I think it is extremely important to retain a relationship between a scientific center and the provision of clinical services. And I heard previously about the fantastic development of from Brussels on the provision of in vitro fertilization, IVF services here in a continuous relationship. Not failed clinicians from academic institutions that have now decided to make some money just before they die, but a continuous relationship. Now, when new technologies come, I am 1,000 times in favor of the new technologies because they have the potential of advancing things. But when they come and they are promoted to people that are not aware of the goodness and the badness of those technologies, they always lead to a greater harm than good. So in that respect, I believe the cell-free DNA test must be done by people that are actively involved in fetal medicine. But that, of course, will go against the companies. The companies want idiots to buy their product. They want to sell. They want people that understand that Big Mac is better Mac. It's not bad for you because it makes you fatter. It's good for you because you buy it from them. And that is the challenge.